Hello, and welcome to the January 2024 edition of the CNS Journal Club podcast. My name is Katherine Holste, and I'm a sixth-year neurosurgery resident at the University of Michigan. Today, we'll be discussing the article titled Social Determinants of Health and Associations with Outcomes in Pediatric Patients with Brain Tumors. There has been increasing interest in understanding the effect of healthcare disparities on outcomes in various neurosurgical conditions, and I'm glad to see more data coming out about pediatric diseases specifically. It's an honor today to discuss this article, and I would like to have each guest introduce themselves. First, we are privileged to have the senior author, Dr. Renee Reynolds, on the podcast to discuss her paper. Dr. Reynolds, can you briefly introduce yourself?
Yes, hi, good evening, and thank you for having me. As you alluded to, I'm Renee Reynolds. I am a pediatric neurosurgeon at the University at Buffalo in New York, and I'm also the program director there.
Fantastic. Next, we have Dr. Neena Marupudi as our guest interviewer. Dr. Marupudi, can you briefly introduce yourself?
Hi, I'm Neena Marupudi. I'm one of the pediatric neurosurgeons at University of Michigan and clinical associate professor, and I'm really excited to be here.
Finally, we have Dr. Kimberly Huang as the co-chair of the CNS Journal Club podcast, who will be moderating the podcast with me today. Dr. Huang, can you introduce yourself for any of our newer listeners?
Hi there, I'm Kimberly Huang. I am at Emory University, where I am a tumor neurosurgeon, and I am looking forward to today's discussion. Great to have everyone.
Thank you. Dr. Reynolds, can you please start off by summarizing your paper? It might be helpful for our listeners if you shared with us the definition of social determinants of health, what variables you looked at, and what you found in your analysis.
Yeah, and before I get started, even though I'm representing this paper as the senior author, I do have to give credit to the medical students and the residents who really were the brainchild behind this idea and delved into gathering all the data and putting it together. And I definitely was more of a guide to them than the inception of this idea. So I want to make sure they get credit where credit is due. But essentially, as you had alluded to, social determinants of health are becoming more and more a focus of how it impacts the patient's overall care and outcome. And there have been some great studies to look into isolated social determinants of health, but our main goal was to look at, if you have more than one, is there a cumulative effect on that patient's specific outcome? And we chose the patient population of pediatric brain tumors. Social determinants of health are essentially any non-medical factor that may influence health outcomes. And the CDC actually further defines those into 5 separate categories, of which there are multiple different variables people can look at. So education, access and quality, healthcare access and quality, neighborhood, and economic stability, to name a few. The ones that we specifically looked at was race, public versus private insurance, median household income, and then the distance from the tertiary medical center that the patient lived, alluding to that being a factor that may influence their access to care. And even though we're really looking at outcomes, the outcomes that we're primarily interested in for the purposes of this paper were, ER visits and missed follow-up appointments. Although I think there's a great deal of information that can still be looked into and gathered about true outcomes, their progression-free survival, how many times did therapy have to be held for certain challenges versus their overall quality of life. There's so many different things that can be looked at.
Thank you so much. Dr. Marupudi, since you're our guest interviewer, would you like to start off with some questions?
Oh, it would be my honor. Dr. Reynolds, your group's paper is so incredibly interesting. Your paper presents how the influence of social determinants of health, and particularly complex care or subspecialty care, can significantly affect outcomes. And it's so important, I think, that this data be presented to support these hypotheses. So I want to applaud you and your group for what you've done with this paper. It's so well presented. And what I want, my question is going to be something that kind of encourages the group to highlight what we can do as pediatric neurosurgeons. So I want to start off by asking you, what do you feel is the one social determinant of health that we as pediatric neurosurgery providers should focus on now in order to improve our care of patients immediately or in the short term?
Yeah, I think that's a fantastic question. And reflecting on the social determinants of health, there are many factors that we have no capacity to have an influence over. Examples include race, median household income, those things we can't have any direct impact on. So in reflecting on especially the data that we gathered and the outcomes that we looked for, I think access to care is the biggest area where we can have a positive influence as providers and as healthcare systems. Certain things that hospitals may be able to assist with is even having patient navigators, social workers, opening conversations amongst those people. And even as providers, when we see patients, to your next appointment is at this time, is that going to be a challenge for you to make? Does this work for your schedule? Are there transportation issues that we might be able to assist with? So it's not an easy problem to solve, but I think the lowest hanging fruit of all this is the patient's specific access to care and how we might be able to mitigate that.
That is an excellent explanation and an excellent choice. I think there's a lot of hospitals these days that are looking to using patient navigators, and I think that's an excellent point that you make. And your answer really helps us encourage hospitals to invest in social workers, because I think that is a group that we often lose as our first line of healthcare providers that gets to go when the finances get tough. So thank you for pointing that out. I also want to point out that the role of social determinants of health for pediatric patients is very complex due to the potential complexity of these factors and how those factors affect caregivers. It's not the pediatric patient that necessarily has these social determinants of health, but rather their parents or their caregivers. And it's a trickle-down effect and can be, multiplied in the care of the pediatric patient. So when I was reading your paper, I was really intrigued by finding that the larger tumor volume at initial presentation was associated with the lower income in the patient or the patient's family. So this is something that I think I wanted to ask you more about. In your opinion, is this more related to limited access to care? Or do you think that this perhaps could be something that is more related to a lack of trust in a medical system? Or is it a combination of both?
Yeah, that's a great question. And I think it's probably multifactorial. But I do think that the less resources you have, and resources can be defined in so many ways, whether it's time. If you have a household that's running with one provider and that provider's working multiple jobs and just doesn't have the physical time to take their loved one to seek medical attention, to logistics such as transportation, if they don't have access to a vehicle or public transportation to even get to a center to be evaluated. And then, of course, just the resources that are necessary to pay for that medical treatment. I think oftentimes there's probably the sense of, well, these common symptoms that generally present in the setting of a brain tumor, whether it's headaches or nausea or, a little bit of sleepiness, those often can be explained by other conditions. So I think oftentimes these families are probably thinking or hoping that it's a simple explanation that will resolve on its own. And because of their limited resources and access, are pushing out having an evaluation even farther than other people who do have better access and better means to be assessed and evaluated. And that's, I think, the bigger challenge, because obviously we all know the earlier we are aware, the earlier we intervene, theoretically, the better the outcomes. So education is huge, and letting them know where they can be evaluated, what sort of things should be brought into a physician's attention. We think about mental health and the hotlines that are out there. If you have a concern, please call. Is there the opportunity to even have something similar to that where people can free of charge call in and say, these are my child's symptoms. Is this something I should be concerned about? And guided as to whether or not that's something that really should be evaluated further.
Great, thank you so much. So Dr. Reynolds, when I was reading your paper, in your group's paper, which was excellent, I was just thinking about the cohort that you all had constructed of pediatric brain tumors, which admittedly, there's the N is very small because there's not that many in a single center review. What do you think the benefits and possible detriments are to including all types of pediatric tumors in your analysis? So for example, in diffuse pontine glioma, those patients, there's no clear-cut treatment for that. They might have to enroll in a clinical trial. They're traveling to different states. They're participating in quite a bit of care. Whereas for other tumors like pilocytic astrocytomas, they could potentially have a curative operation, have much less burden of follow-up and imaging and care. So what's your opinion on including the whole gamut of pediatric tumors into one cohort versus like further splitting it up into separate subset analyses?
I think that's an excellent question as well. To further clarify, we only included patients who either had biopsy or resection, so it was a proven brain tumor, and given DIPG is more of a radiographic diagnosis, they weren't included in the analysis. It's not our routine habit to biopsy patients, with the exception if they're going on clinical trial elsewhere and they need that molecular analysis. So I don't think the DIPG population necessarily skewed this data, but I think it's an absolutely fantastic question that needs to be looked at further, because you're right, people primarily in that patient population seek care elsewhere and oftentimes from multiple institutions. So the snapshot we're getting locally is probably not representative of their overall care. But interestingly, one of the things that I found interesting in the paper that maybe not many people even honed in upon was that outside of germ cell tumors, no matter what category of social determinants of health you fell into, whether 0, 1, 2, or 3, the high grade versus low grade versus pathologic diagnosis was pretty equivalent across the board, which I was not necessarily expecting. We always talk about possible environmental or genetic factors influencing the development of these. And you can further hypothesize that maybe certain patient populations or environmental factors that you're exposed to may raise your risk of developing one versus the other, but that really didn't hold true. So despite not separating or accounting for those specifically, it was pretty equally distributed across the board. And I don't believe it personally skewed this specific data set.
Thank you. And then as we move forward, because I hope that we as a group of not just pediatric neurosurgeons, but neurosurgeons in general, will start to think more about social determinants of health. How can we better study this problem? And do you have any suggestions for how, as a group, maybe the CNS or AANS as governing bodies, we could help promote these future studies?
Yeah, I think as you mentioned, the numbers are low. So I think we gain a lot of advantage by working together and pooling our numbers and seeing what the experiences for patient populations look like across the country. Certainly Buffalo is one snapshot, but in different communities, you may get different data and they may have different needs. And so it might not be a one solution applies to all areas type conversation. So I think pooling our resources, similar to how we do with hydrocephalus, to help better the care that we provide to people will be really useful and beneficial. And I think we as a community probably need to come together and figure out where the biggest areas of opportunity are, and maybe even develop things like algorithms that we can easily and freely institute in our brain tumor clinics. As an own introspection to how I care for patients, I go in and I assess their clinical symptoms. I do a neurologic examination. We talk about imaging and the follow-up plan. But I know for a fact I'm not frequently asking, is it tough for you to get here? Does this day work for you? Our brain tumor clinic is held on one specific day of the month, and they're given a specific time slot that may not work with their work schedule or the way that they have access to transportation. So I think, certainly social workers and clinical navigators and coordinators help with that, but we should also take some of the responsibility. And I think maybe if it comes from the physician, families will also feel a little bit more comfortable reporting things that may be challenging for them. If it's an open conversation and we show that we care and we understand what influence that may have on that child's overall health and outcomes. So I think, again, just looking across the board, pulling the data together and figuring out the low-hanging fruit of how we as a surgical community can help bond with these patients first. And then from there, you can grow things bigger. If there's one specific area that we see that really benefits, putting together certain systems amongst multiple hospital systems that may be able to benefit folks, maybe mobile clinics, telehealth was something that was brought up. And I think those are all great ideas.
Yeah, I think it would be really interesting if we could add something like this to the HCRN or some other like major databases, just so we can start studying it as a multi-institution, all different locations across the country. It'd be really beneficial. And as far as asking the patients goes, I think that's something that not a lot of neurosurgeons do. Dr. Marupudi does it when I've been in clinic with her. She'll ask the families more about their social situation and things like that. And one of my functional neurosurgery attendings who works at the VA is very good about asking patients in the wintertime, do you heat your stove with wood, or do you, like for your house, or do you have electricity? Because if I'm going to do back surgery and you're going to have lifting restrictions for 4 to 6 weeks and you can't cut wood to heat your house during the winter in Michigan, it's just going to be a no-go. So those are all things that I think we can incorporate more into our practice. Dr. Huang, did you have any other questions or any questions in general?
Yeah, I would have to say I would agree with Dr. Reynolds and Dr. Marupudi that, my practice has changed, or the questions how I interview my patients, because I see mostly adult tumor patients, and even just asking in Georgia, where are you traveling from? Because, our patients, and just like the pediatric patients, they have to get adjuvant care afterwards, right? And so although they may have surgery with me because there may be limited neurosurgical providers, depending on the location, often they can be seen closer to home as an adult patient, so that actually helps a lot to ask them where are they from, how far are they traveling. So yeah, I think the more we kind of address those questions up front, the better we can plan for their adjuvant care. Probably less so for the pediatric population, because I think the centers are more, tertiary care centers, but certainly something that has changed. So, we talked a little bit about solutions. One of them is asking questions, being more inquisitive in our visits, to help social determinants of health disparities and those kinds of things. And, at my hospital, they always bring up telehealth was supposed to be a real solution to kind of help with these missed visits and post-op things and a lot of these follow-up visits that we need to have for their adjuvant care, even beyond neurosurgery, for radiation oncology and oncology. So in your practice for pediatric brain tumors, or in general, actually for pediatric neurosurgical care, I'm always curious how this has been, whether this has been effectively utilized for patients who have, multiple social determinants of health. For example, in my practice, actually, a lot of patients don't have reliable access to internet sometimes, or especially if they're older, they don't feel comfortable using the internet or, figuring out the telehealth system. It's a real barrier for them. So I don't know that we've actually been utilizing it super effectively. Just kind of curious as to how that's been working out in the pediatric population, maybe both in Buffalo and at Michigan.
Yeah, I'd be happy to tackle that first. I think there's certainly an appeal to telehealth, and it's attractive on many levels. In my experience, when it works well, and it can be very useful to both you and the patient, and can circumvent some of these major challenges that patients can have in terms of transportation or time. I found, however, more likely than not, it became a challenge and didn't really satisfy what I felt was necessary to thoroughly understand the situation or how the patient was doing. In Buffalo, we treat a very diverse patient population. We treat people from several hours away who live in the southern tier and have spotty internet access. We have folks who are a higher percentage living under the poverty level. So their consistent access to a telephone, whether it be a cell phone or even a landline, is very intermittent and limited. And, I was having patients when we were in the throes of telehealth, because there were no choice, that were driving to a spot that provided good internet and cell phone data access. And then, they're in a car and the baby's in the back in the car seat and you're trying to assess them. And it didn't work very well. I think if we can figure out a way to make it more consistent, and maybe set the expectations for the visit even a little bit better upfront. I would have parents show up for the visit without the child at work, not realizing that they had to actually have access to the child for me to see the incision or attempt a neural exam. So I think there's a lot of potential, but I also feel like it's an imperfect system, and there definitely needs to be some improvements for it to be a consistent way of assessing patients, at least in my personal experience.
I agree. I think that the use of telehealth is particularly affected by social determinants of health, both from an access of internet to having adequate video cameras or telephones to be able to, or video telephones, or the latest iPhone to be able to have good viewing. And much like Dr. Reynolds was commenting on, we have a patient population up in the Upper Peninsula, Northern Michigan, and then patients that come even from the Metro Detroit area. And their understanding of when to log in, when to access, and when they cannot, being able to utilize a phone to reach them and help them through that process, it takes up a lot of valuable time that can be dedicated to caring for the patient. And so those logistics from both an education level, financial level, all of those things play a factor. And I think ultimately it's very hard to really know if you're making the best medical decision without seeing the child or being able to connect with the parents in person. So it is very imperfect, but when patients live very far and you already have a strong relationship with them, I think there's really great utility to utilizing telehealth services.
Sounds very similar, honestly, to the adult side. Very similar challenges that we have.
Yeah, and I think sometimes I wonder if I'm getting more through a telehealth visit than a simple phone call. By the time you're working through the internet access challenges and the connection and trying to get the child to stay still and the video lined up perfectly with whatever you're trying to assess, and trying to build a relationship with that child via video versus in person, which I don't think is as easy to establish. Sometimes I oftentimes feel I would have a better assessment of the situation if I did just talk to the parent by telephone in a more controlled, calm environment, getting their perspective. We all know how valuable the family's input is. They know their child best. So sometimes I wonder if the video is even really necessary.
Dr. Reynolds, I have one more question for you. Why did you choose pediatric tumor population? Is it just your area of expertise, or was there something specific for this population of patients in pediatric neurosurgery that you felt you would be able to pull certain details of inequality or social determinants of health from?
Yeah, there was a few factors that went into that. I think the first is that these patients generally receive pretty longitudinal care that requires multiple follow-up appointments, and outcomes are obviously something that are very important in terms of their overall success of treatment. And so we felt like not only was the potential findings really something that we would work towards improving the patient's overall health for the future of these patient populations, but the ability to actually make a determination about how they affect them might even be a little bit easier. If you think about the trauma population, once they recover, we don't routinely follow them up, or even patients like Chiari, you might be seeing them then once a year. And we might not even spend as much time trying to get them back into clinic if they miss an appointment, because you make the assumption they're doing well, where we really go out of our way to make sure that there's consistent follow-up with the pediatric oncology patients if we can. So I think it was just a multitude of those factors. And, one thing I wanted to bring up just as an idea that's probably not going to be of popular, thought, but, the access to care issue, as I mentioned earlier, I think is one of the biggest challenges. And so we have people with multiple missed appointments. You start to think about, well, why may that be? It's probably partly transportation, but it's probably partly employment as well if they're working during the day. And that's mostly when our clinics are held and they're missing multiple days of work already for therapies and all sorts of other things like their imaging. Is there need to be a little bit more ownership on our end of being flexible with those things, where we offer more afternoon or evening clinics, or maybe weekend clinics where patients might have the capacity to actually follow through with those appointments, because it would, from a lifestyle standpoint, match in better with what they were able to physically attain. But we're so used to these specific clinic hours when we have our support staff, but maybe the onus falls a little on us to extend those opportunities a bit farther from what we traditionally offer. What are people's thoughts about that?
I feel like we're often in the hospital at nights and weekends, so I don't know that for us it would be, it's certainly obviously, from as a provider, it'd be additional work, but I think that's a really, a very valid point. It's just sort of like you mentioned, your support staff and everything that comes in a clinic to help run that. Is that necessary for all visits? I don't know. And the bureaucracy and the infrastructure, sometimes you just need to see a patient, and it's a quick visit. And you don't need all of that bureaucracy that they have to go through, right? I do know that as we've expanded our imaging, so, obviously for tumor patients, you need a lot of imaging, and it's really helpful if they can do it the day of if they're traveling to see you, so that just one visit, you don't have to come back. It's really awful when they have to go one day and then come back and see you another day and travel twice. So as we've expanded our imaging opportunities with our radiologists so that, it's more convenient for patients, and they even have now Saturday appointments and those kinds of things, which previously were pretty limited. I think that's helped people a lot with access, at least from at least the imaging standpoint of things. So we don't offer, weekend or nighttime clinics yet, but I think it's a very valid point. I think, as the provider, or the neurosurgeon, it's not so hard for us, maybe depending on, that kind of thing. But I think the support staff might have a little bit harder challenge with that.
I feel like I've only thought about using weekend clinics when I'm backed up in my weekday clinics. And I almost feel like it's wrong to be like that, right? I've got to find balance in my life. So I feel this tug this way and then the other way. I want to do this for my patients and this population that I love. However, I also want to take care of myself and my family. And the more time I give in that way, am I actually losing a part of myself? And will I not be able to provide the optimal care because I'm not taking that self-care as well? So I think it's a really hard balance, but such an incredible and important point to make. And since you made a potentially unpopular comment about this, I want to throw in one more and a twist to this, because this is an all-female panel. And reflecting back to what we started with, the definition of social determinants of health, do you think potentially that the social characteristics or identifying factors of your provider, that is maybe even female versus male providers, or certain demeanors of providers, play a role in their outcomes as well? And this is something that has been published in other specialties, but is that a social determinant of health? I mean, technically, if you follow what the defining term is, it's any non-medical factor. And so who your provider is still a non-medical factor. And we haven't looked a lot at that in pediatric neurosurgery or in neurosurgery per se, mostly because we have a small population of women in neurosurgery. But I would love to hear Dr. Reynolds and even Dr. Wong, your thoughts on that piece.
Yeah, I think pediatric neurosurgery might be the perfect place to do that, because the numbers actually look far better for female representation, not only in terms of providers in pediatric neurosurgery, but also in positions of excellence, if you will. So people who are represented on committees and boards across the country and their involvement. So I think it would be something that could be done for sure. And I think you're absolutely right. And, a topic that's not necessarily easy to talk about or think about, but again, if it's going to have an influence on patient care, what can we learn from it either way? And how can we apply that to the patients that we see in the future? So I think it is definitely the right arena to look at something of that nature.
Yeah, I agree. I think the great part, every time I do interviews now for resident applicants, I see so many more higher percentage of applicants that are females. So I think we are hopefully reaching that critical mass to really have enough power. People use that term very loosely, but enough power to really understand that question. It'll be interesting to see whether or not the trends follow. I always see all these new articles coming out rather recently, and the controversy they cause about outcomes related to gender. So it'd be interesting to see whether our field does follow what has already been published in the general surgery literature about having, differences in providers' gender and the outcomes that patients have. But I would agree with Dr. Marupudi. If we're being technical on the definition of social determinants of health, it's a very unique way to look at that. And I'd honestly had not thought of that as a possible interpretation of those disparities. So that's great. Something to think about.
Yeah, and along those same lines, one of the things that we discussed very briefly, but I think is a huge void, and I know in my own health system, I fight tooth and nail and have made very little headway, is the support staff, social workers, patient coordinators, clinical coordinators, health homes, which we used to have in Buffalo and have fallen to the wayside. And it's because there's no financial support for those things and there's no insurance reimbursement, but those are also non-medical things that may influence a patient's outcomes. So looking at, does the specific brain tumor program have these aspects as part of their care. How frequently are they touching base with the patients? What are they able to provide in terms of help and assistance with access to care? And then looking at these same factors, missed appointments, follow up in the ER, missed treatments, things of that nature, I think is also very, very important. And how do we work as a community to advocate universally of the importance of these things in the care of our patients, because it hasn't really been heard, at least in my institution, as loud as I think it needs to be.
Well, thank you all so much for that discussion. It was fantastic. And thank you again for taking the time to be part of the January edition of the CNS Journal Club podcast. We're just about reaching time right now. We hope that this discussion about social determinants of health does spark interest in your own clinical practice and maybe leads to joint efforts to further study them, as we were talking about before. For those interested in learning more about the article that's presented by Dr. Reynolds and her team, the full article will be out the January 2024 edition of Neurosurgery for you to read. We'd also like to remind you that this podcast activity is complimentary to all CNS members and is worth 1.5 CME. Thank you so much for listening, and please join us next time for the February episode.